Hello everyone, welcome. We'll just wait a minute for everyone to come in. Great, we've still got a couple more filtering in. All right. Welcome everyone, good evening. Thank you for coming. My name is Amy and I'll be hosting tonight's webinar. This instalment of the Rural Health webinar series forms part 2 of the Rural Emergencies 2-part series on management of emergencies in a rural setting. The webinar will build on the theme of procedures, protocols, and people factors with the opportunity to discuss 2 case studies. It follows on from part 1, Rural Emergencies, Procedures, Protocols, and People Factors. Our presenter this evening is Dr. Anthony Wong. Dr. Wong is a GP anaesthetist from the West Gippsland, Victoria. In his previous career, he was a rural GP in a small town setting in the Western District, where he also provided obstetric services. Dr. Wong was one of the first graduates of the JCCA program after completing his anaesthetics training in the UK during the 1990s. He's actively involved in simulation teaching for both undergraduate and postgraduate students, and particularly enjoys leading interdisciplinary sessions in the operating theatre and in PROMT or prompt training. All right, we'd like to begin tonight's webinar by acknowledging the traditional owners of the lands that we are coming together from and the land on which this event is being broadcast. I'd like to pay our respects to their elders, past and present, and would also like to acknowledge any Aboriginal or Torres Strait Islander people who have joined us this evening. And just before we begin, I just have a few housekeeping things to cover. So participants are set on mute to ensure that the webinar is not disrupted by background noise, but we do encourage you all to use the Q&A chat to ask any questions, and these questions will be addressed at the end of the webinar in the Q&A session. And finally, the webinar has been accredited for 1 hour educational activities CPD. To be eligible, you must be present for the whole duration of the webinar. We also kindly ask that you complete the short evaluation at the end of the webinar. This doesn't take very long, it should only take a few minutes to complete, but it really helps us improve the format and the content of our future webinars. And with the learning objectives for tonight, by the end of this webinar, you'll be able to firstly discuss important procedural skills guided by the Australian resuscitation protocols in basic and advanced life support in a general setting, and 2, discuss the importance of a structured approach and people factors for managing an emergency in a rural hospital setting. Thank you for listening to that housekeeping. For now, I will hand over to our presenter for this evening, Dr. Anthony Wong.
Right. Thank you very much, Amy, for the introduction, and thank you to RSCGP for asking me to do this webinar for the second time. As we said, the learning outcomes is as listed with the important life-saving procedural skills and a discussion on basic and advanced life support, and talking around 2 emergency scenarios to highlight this. Just a bit about myself. I'm a rural practitioner. I'm not a FACEM, so a bit of disclosure there in that I'm not a specialist emergency doctor. I was a 1991 Monash Uni graduate, and I was, as Amy said, a small town rural GP in Terang in the Western District for 7 years. And now I currently do full-time anaesthetics in Western Central Gippsland, Victoria. I'm also a instructor for ACRM, as well as teach a lot in undergraduate training with Monash Uni. So what's relevant for this evening? Well, originally we started this journey with Dimitri, one of Amy's colleagues, in that he reached out to me last year and said, an evaluation survey shows that rural GPs want more education on emergency medicine procedures, protocols, and retrieval communication. And hence, that's where we pivoted from in terms of giving this first talk last year. The thing is, I suppose I understand where you're coming from your educational background and almost 30 years of transferring patients out in a rural setting. and a knowledge of the limitation of skill sets of the infrequent rural general practitioner. The problem is these are halo events or high acuity, low occurrence events. The cases that I'm going to present to you happened to me while I was a small town GP in Terang, but they happen once a year. And so being able to bring out the skills and remember the protocols and get your confidence up for these. I've been there, and but I wanted to share with you some useful tips and tricks and some useful resources I've discovered. Unfortunately, it's only Victoria. And to break it down and to simplify it and not make it so overwhelming and complex. So as I said, the disclaimer, no conflicts of interest. I presented this last year and the feedback was overwhelmingly positive. But as you know, our mind gravitates to a negative bias, and I focused on one negative comment, which was the content was a bit basic sometimes, and the participant was hoping for a higher level of difficulty. So of course I reached out to Dimitri, and he then offered maybe we'll do a part 2. So I will talk about this in a bit, some of the procedures, protocols, and people factors in a bit more depth. But having said that, I still am very conscious of the fact that it was the majority, as in 99.9%, presented it as a very informative, excellent content and clear presentation. So I must have hit the mark okay for the majority, and I don't want to take that away from the majority. But if any participants would like more detail, please do not hesitate to pause and ask, or raise it in the Q&A at the end. Or attend a formal emergency course, which is very worthwhile, very hands-on, and will give you lots and lots of learning and that detail and that higher level of difficulty that participant was looking for. Okay, let's start off with a case to warm up with. In Terang Medical Clinic, Arthur collapses in the waiting room. Now, in terms of presenting Zoom-wise, I think a good way is for me to present a real-life demonstration. And there are lots of really good resources out there in the YouTube world and the Vimeo world. But this is probably the best one that I've seen. This is what I would hope for, or what I strive for in terms of best practice management. And I'd like to see this happening to my patient Arthur, who collapsed in the waiting room. Okay. What I'm going to do is I'm going to play and pause and discuss. A lot of protocols, procedures, and people factors will be demonstrated in this excellent video. So as you know, it starts off with doctors, A, B, C, D, E. And this is a presentation of a deteriorated patient, someone who's had a cardiac arrest. Now remember, cardiac arrest can be all different forms. The most common form being a VF, as in possibly this scenario, but there are other forms such as a hypoxic arrest or traumatic cardiac arrest, which have their own differences in management. She checks for dangers and is checking for response and looking for a particularly verbal response. After that, you can categorize their conscious state or get a rough ballpark with their AVPU score, whether they're alert, responding to vocal, painful, or unconscious stimuli. And only responding to pain or unconscious means they're in the poo or they're in a fair bit of trouble. CPR. Can you hold it back up, please? Sure. Okay, this is essential. CPR without, and you notice she hasn't checked for a pulse. She hasn't fluffed around and done anything. She's just started CPR. If the patient doesn't need CPR, they'll push her away. But the thing is, early CPR and good effective compressions keeps the patient alive. It perfuses their brain, heart, kidneys, and all the essential organs, and helps you essentially buy time. It's important to do correct CPR in terms of the correct rate, the correct rhythm, the correct depth, and the correct site. So middle of the chest, lower half of the sternum, you see her technique is perfect, straight down as she's compressing that heart between the sternum and the thoracic spine. She's doing 120 beats per minute and compressing a third of the chest or at least 5 centimeters.
Cardiac arrest, can we have clinical support and another correction? You put the metronome on when you're putting that on, please? Sure.
So in this particular case, because it's BLS, we're using an AED. This is the AEDs that you'll most likely have in your clinics, but also that is found in the wider community, where you have a man or a woman talking to you and giving you clear advice. They can analyze the rhythm. However, we need to maintain CPR while it's applying and to minimize hands off the chest.
Hands off.
You're not in the front. You're not shot and fly.
I'm sorry.
You never shot.
Shocking now.
In ALS courses, this is an essential component to pass in terms of safe defibrillation. You notice her verbal and her non-verbal technique in terms of making sure that we don't have any inadvertent shocks. There's also, and using clear communication, closed loop communication. You notice how oxygenation has been pushed right back. The theory behind this, and as you know, that there's been a lot of talk of only chest-only compressions-only CPR. The giving mouth-to-mouth or wasting time trying to oxygenate a patient who has collapsed with a good level of oxygenation in the situation of a VF cardiac arrest, it becomes lesser of a priority. At the same time, I want you to note how they do manage the airway in terms of good technique with bag mask ventilation and then rapidly moving on to a supraglottic airway or a laryngeal mask airway. It's important to, if you're going to do it properly. If you're not ventilating them correctly, all we're doing is filling up the stomach and putting them at increased risk of aspiration.
Change 15 meters.
So notice the two-handed technique, and the airway person is not releasing her hands to bag the mask. She's making sure she maintains an excellent seal. So as an airway person, I just see this as just a beautiful, perfect demonstration. Now, this is at 2 minutes in real time. You can see there's quite a lot of time to do things in between. Those 2 minutes are the checkpoints to check the rhythm. And now she's preparing a laryngeal mask airway. And this will allow her basically just to free up hands.
Okay, just putting our airway now. Five, 26, 27, 28, 29, 30. Okay, just checking. Good rise and fall. 11, 12, 13, 14, 15, 16. 5, 26, 27, 28, 29, 30. Okay.
So what they're meaning in there is that it's a closed system now with an advanced airway. And so rather than needing to time 30 to 2 or 15 to 1, they only need to do 10 breaths per minute. So now we're at this next checkpoint of 2 minutes. To maintain those good quality compressions, you notice how they have swapped positions so that you have someone fresh to maintain those good quality compressions.
Delivering shock.
On job delivery.
My God.
So we're on to the second shock now.
Sorry, this is very. We got called to a home address with a 54-year-old male with chest pain. Vomiting. When we got here in cardiac arrest, we commenced CPR. Jenny, do you mind if I take the leadership role? Can you take over the airway management for me? Reggie, can you go and check home alone if there's any indication of medications or past history? See if I can find.
So at this point, she has a team. And the thing is, another good part of this video is presenting it with 2 rescuers. Often in a rural setting, we have a limited number of rescuers or resuscitation personnel, and we've got to use them as efficiently and optimally as possible. When she has the helper arriving, she is able to delegate and get a little bit more information, such as the history of the patient. That's the whole challenge, I suppose, of emergency medicine, in that our day-to-day office work involves a history, examination, investigations in that sequence, and everything suddenly is all jumbled up, not to mention the stress of the situation. She's maintaining some calmness to it all, and she's asked to be the leader. In terms of allocating roles, back to the history, we often use a very shortcutted, quick mnemonic for a history, and that's the ample history, looking for allergies, medications, past medical history. In my situation, it's a last meal and events coming up to this situation. The whole principle, or the whole underlying principles of being in a crisis or emergency situation is our mind humanly just goes blank, and having these structured approaches and these things to hang on to helps make it a bit more smoother, I suppose. In terms of the leadership role, notice how you'll notice how she actually stands back so that she's not hands-on, and this cognitive offloading is really important for her to function effectively, as well as her communication skills, closed loop feedback, using names, and also using cognitive aids and a checklist, as you'll soon see.
We've identified the team. We've got full 360-degree access. Jenny, could you check that the players are in a really good position? Yeah. All good. And Jenny, can you give me an approximate time for the next shot, please?
Roughly about 30 seconds. I was not going to find anything obvious in there.
Good CPR, Mel. We'll change again. On our shoulder and charge. The metronome's on. Yep. Jen, you got a very good airway?
Yeah, have a good airway, but I can't go.
Reggie, could you check that the reservoir bag's inflated?
Yes, all inflation.
And then check that the oxygen cylinder is still full. And if we have a replacement. Hands up. Move. Reggie, can you join in?
Shock advised. Stay clear of patient. Shock.
I'm saying.
I'm safe. Shocking now.
Now, shock delivery.
Commence CPR.
4. Instigated. Begin CPR.
30. I'm just going to call the EOC. We're at Hometown A1. Currently had a cardiac arrest. We're ambulance officers. We'll call for a chest pain. Found a male patient in his early 50s. Cardiac arrest. We commenced CPR. He's had a total of 4 shocks. We have an eye-gel in situ. And he is currently in CM 9:30. Just looking for some advice. Yeah.
And you can see from her ISABAR presentation, identification of self, situation, etc., that the communication is probably one of the most important things here, and it's something that we can all do in a very structured, unhurried fashion. Okay, we're going back to the slide. So I think at this point, I wouldn't mind just pausing a bit and into the chat box. If people can, in the next couple of minutes, just list out the relevant procedures that are important, or the procedural skills, I suppose, that are important for basic life support. All right, so I'm not sure if that'll come out. Let's have a look in the chat. Anyone putting up anything procedurals? No. Any relevant protocols that people want to put up that might be that are especially relevant to this presentation? Or the people factors? Okay, so the procedures would involve a good effective CPR, being able to apply the AED and use it safely, similarly, and basic airway management, and also insertion of an eye gel. Relevant protocols would be our BLS algorithm and our use of their ambulance checklist. And people factors, you can see how they have good team delegation, good leadership, clear, concise communication, as well as decision making. So we talk about the chain of survival, which is demonstrated well here in terms of early recognition and call for help, early CPR, early defibrillation, and post-resuscitation care. We have some chats to look at. Let's have a look at here. How to adjust the defib dose for children. Let me deal with the questions at the end of the session. Thank you. So looking at the procedures, the CPR, defibrillation, post-resuscitation care, and basic airway skills. So the big question is, as we progress into ALS, what would be the additional management we could include? So this is moving into ALS, which is advanced life support. And again, there's another algorithm, which is from the Resuscitation Council. We really concentrated on this, and then the AED took over and assessed the rhythm as being shockable or non-shockable. It shocked and then gave CPR. But you can see from here The only additions with ALS is drugs, such as adrenaline, and use of an airway and waveform capnography, and access to be able to administer the drugs. The important thing to consider and correct is the reversible causes, the things that we can treat, things we can deal with. And we commonly call them the 4 H's and 4 T's. And this is the source of the different causes of cardiac arrest, such as hypoxia or hypovolemia that can occur in conditions such as a respiratory arrest or anaphylaxis and asthma, or hypovolemia, such as a traumatic cardiac arrest. And these hyper and hypokalemia, metabolic disorders, hypothermia and hypothermia finish off the H's. Tension pneumothorax, tamponade, particularly relevant to trauma, and toxins and thrombosis, both pulmonary and coronary. Okay. So the important people factors, just to show this for this diagram, you noticed how part of their doctor's ABCD, they called for help early. The first point about declaring a crisis and calling for help for the deteriorated patient is challenging because we don't often see this. We don't often see a collapse or seriously unwell patients. So there's almost like a cognitive, this can't be happening bias. And that can be enough. But once it's declared, people can spring into action. Clear communication is really important, as it was demonstrated well in this video. Team coordination and taking on a lead role, good decision making, especially if you're using a manual defibrillator and having to decide between a shockable and non-shockable rhythm, and anticipation and planning. So at that 2-minute mark. Being able to think about rotating the compressors, charging. And when we're charging, the technique that we often teach is a technique called coached. Coached makes sure that we minimize time off the chest. So that's compressions continue, oxygen away, all others away, charging. So that person that's still doing CPR continues with their CPR while we're charging. And then to evaluate the rhythm, we have to do the H part of coached, which is hands off. Then you can see what the underlying rhythm is. You evaluate the rhythm and then you either defibrillate or disarm. Okay, we have a second case now. That's how we go. We're going for time. Spot on. In Nurut, Jim has had a hay bale accident. This has all fallen over him. So we have a case of a multi-trauma. Presents with reduced consciousness, bruising to his left chest, injury to the left leg, tachypnea, hypoxic, tachycardic, hypotensive. Lots of bad things are happening to poor old Jim. The ambulance are on their way and they summarise possible head, chest injuries and an obvious open fractured femur. So what we're delving into now is a case of a deteriorating patient where, again, we use our letters of the alphabet in terms of a doctor's ABCD approach. And I want to demonstrate to you how we can deconstruct a very complex scenario by dealing with each of the pathophysiology one by one in a systematic and structured way. Again, trawling through, I found a really good video to highlight this. It's a bit old, it's a bit North American-ish. However, I will again pause and discuss so that we stay on the right track and focus on the main learning points.
So Tracy, what do we got coming in?
Dr. Boyer, I'm on the field, heart rate is in the 120s, blood pressure is 90/40. He's got an obvious left femur fracture. They have him in a hair traction splint.
He's backboarded, collared. They have him on some oxygen. It sounds like his O2 stats are in the 88 to 93%, and his GCS is poor.
So minimum.
So at this point, we actually have some opportunity to prepare. We have a lead, we have his team, they are focused, they are using clear communication. He's briefing them or she's briefing them so that they all have what we call a shared mental model. And they're in the right environment. They're in their resus bay. They have all the kit there, but most importantly, it's familiar.
So they got some oxygen going,
They have oxygen.
one IV.
One IV, I think 18 in the right
All right. So it sounds like this guy is pretty injured. We're gonna need to take care of him.
See how he's using a technique of an internal summary? He's summarizing back to the person who's taken the triage call, just to make sure that it's clearer in his head. And this is a technique that I use quite often, and that they're all got the same information.
Things sounds like an airway problem. Sounds like he's in shock. So a couple quick things we need to do very quickly when he gets here is let's make sure that we got our airway stuff ready to go. It sounds like he need to be intubated. So we got everything we need.
I got everything else.
All right. And Betsy, it sounds like he's only got one IV. So when he arrives, what I'd like you to do is put a second IV in on his other side. If it doesn't have one, we'll get some blood out of that when we do it. Also, if you would call the lab and X-ray before he gets here, make sure they come and help us out. And Tracy, when he gets here also, I'm gonna look at his airway while I'm doing that. Can you put him on a monitor and a blood pressure cuff? And let me know immediately what the vital signs are so we can go from there. And I guess the other thing we're gonna think about is this guy's probably bleeding a fair amount from the sounds of it. So let's notify the blood bank and let's get the massive transfusion protocol and standby and make sure that we got that ready to go. Also sounds like this guy is a little too sick for us to keep here. So once we figure out what's going on, let's get the trauma center on the phone because I'd like to talk to them and get him transferred, okay?
Yes, sir.
Right. Any questions?
No.
All right, let's do it.
This is Garrett, he's 18 years old.
Great.
Yeah.
Prolonged excitation,
And then
he's unrestrained,
understand,
and you said he's got an obvious head injury
obvious injury,
and obvious femur fracture?
open femur fracture.
Okay, and that's all you see right now?
The breathing the left side as well.
And his last set of vitals?
Blood pressure is 90 by pound. He's 120 times pat on the monitor. Respiratory rate is about 12. Let's put about that. And he's in a responsive plan.
Any other issues?
Not that I know
All
of.
right, thank you very much.
Thank you.
Again, getting an internal summary of the AMBOs. I don't know about all of you, but my mind just totally goes blank. But once you're able to feedback with that communication and do an internal summary, you're starting off at a good base level.
All right, guys, this guy looks like he's got a lot of injuries, and let's do this in a nice systematic fashion. We'll start with the ABCs. So Tracy.
So the difference with a traumatic or with a trauma is we use our doctor's ABCDE, but often there's some added things which respects the nature of the trauma. So first of all, the main differences is we would start with C, doctor's ABCDE. C starts with compressing any external hemorrhage. So you can see on the patient's upper left leg, there's a bandage. I would want to make sure that that's not continuing to bleed. Otherwise, we need to apply direct pressure again, or indirect pressure with a knee to the groin to stop the proximal bleeding vessels, or using a tourniquet, which is about 5 centimeters above the wound, that's tightened up and reducing that external hemorrhage. Also looking for any other red spots all around the body. And then we move on to airway. And airway always comes with cervical spine control, because we can't assume that he hasn't got a cervical spine injury. The best way is for someone to apply manual inline stabilization while he's assessing the airway and then about to manage the airway, as you'll soon see. And the other thing that we would use now is with the laryngoscope, not just a direct an indirect laryngoscope, which is what he has. What we have now is what we call a video rigid laryngoscope. So basically, this is a screen so that everyone can see what is actually happening rather than just the airway person.
Says in the airway, I want you to put some leads on, let's get a blood pressure. And Betsy, if you come over here on this side and help me with the airway. Looks like he's breathing about 20 times a minute. Sir, can you open your eyes, sir? What's your name? Looks like he's not responsive at the moment. He's got some obvious facial trauma, and it looks like he's not breathing real well. He's a little bit bored.
You said 82%.
Like you said, 82%. So we're going to need to intubate him. So what I would like you to do, Betsy, is I want you to hold C-spine precautions here. I'm going to take the C-spine collar off. And I'm going to put an oral airway in here. See if we can get a little bit better.
So the indications for intubating is that this person's GCS or AVPU score is in the poo. So his GCS is less than 8. He's not responding to pain. He's actually unconscious. So the fact that he's not actually, sorry about that, that he's not actually responsive, he's not actually making his airway patent and definitely not protected. Similarly, he's also severely hypoxic. So all this equals to solving all these problems by putting an endotracheal tube. Now, putting an endotracheal tube is not going to be fairly easy with this chap. He's going to have possible blood and secretions in his mouth, and he's also unable to fully extend his neck because we're worried about a cervical spine injury. So the anatomical position of his larynx will be abnormal. We've got a few tips and tricks for this, including using what I mentioned before, a video rigid laryngoscope, but we would also use other intubating equipment that might help us with that anterior larynx. The thing is, these would be advanced procedures that would need to be trained for. But if you didn't have that training, putting the most important thing is oxygenating this patient. And with the current availability of laryngeal mask airways and third generation laryngeal mask airways, this could get you out of trouble in terms of maintaining oxygenation of the patient and draining their stomach.
All right, let's put this oral airway in. Let's go ahead and bag him here. Responsive. It looks like he's going to need to be intubated. Do we have our intubation stuff ready?
Everything's right behind you, ready to go.
All right, can you bag him here while I grab that?
I got it.
Can you come off for a second? Let me just take a look here. Looks like we got a little bit of blood in there. Let me suck that out. All right. Suction. All right, good. Great. All right, let me just take a peek here.
Let me know if you want some right away, Dr. Boyd.
Yeah, we'll talk with pressure. Great, thank you. All right. See his cords, tubes going in. Great.
Good color change. Good.
Sure.
Okay, at this stage, we need to make sure that the tube is in the right spot. The only way to confirm correct tube placement is to see carbon dioxide. They're using what they call a color change capnography. So that's using a color change, and gold is good, where it changes from purple to yellow. The ideal form is what we call a waveform capnography, and that's an attachment with a lead going through a gas sensor that is on the screen. The other ways of seeing the chest rise and fall, auscultating both chests, seeing misting of the tube, they're secondary techniques of confirming tube placement. They're definitely not the gold standard.
All right, let's get him hooked up to a ventilator. In the meantime, let's put the C-spine collar back on, protect the C-spine. All right, and let me take a listen to his lungs. Betsy, there's a little bit of bleeding there. Put some pressure on that.
C-spine collars have gone out of vogue. There's been quite a few studies looking at the dangers of C-spine collars in terms of raised intracranial pressure sores. The gold standard here would be maintaining manual inline stabilization using sandbags and possibly taping as well.
Can we call for respiratory and a ventilator, please?
I got good breath sounds on both sides, a little bit left on the left and the right. He's got some bruising on his left chest. Let's see what we got.
And in the community, if someone has a potential C-spine injury and they're conscious, we would put a soft collar on, and a lot of ambulances would say C-spine not cleared radiologically. So we're trusting in the fact that a patient who has a cervical spine injury will not move their neck. But then at moments of risk, such as if you needed to transfer them, do their airway, they needed to go to the toilet, imaging, so forth, then we would maintain manual inline stabilization.
We got him intubated, his pulse ox has gone up to 96%. What are our vital signs doing?
Looks like his heart rate's 115 and his blood pressure is 90/40.
All right, so it looks like he's a little bit in shock. We've got airway and breathing taken care of. Is he bleeding? He's bleeding down here on the left.
So before we leave breathing, we want to make sure that the killers aren't present. So I think of the killers from an airway breathing point of view is airway obstruction. I also think of other killers such as a tension pneumothorax, an open pneumothorax, a hemopneumothorax, a flail chest, and cardiac tamponade.
We get some more help. Hey, Will, can you help us?
Dr. Carter, would you like a second IV?
Yes, let's start a second large bore IV. Let's hang normal saline. And how much IV is so please? Put some pressure on that, please. You keep bagging. Start a second IV over here, Tracy, if you would.
And remember the principle behind your cannulas. 2 is better than 1. And we talk about a large bore and with a reduced length, not the really, really long ones. Remember Poiseuille's law in terms of flow rate, inversely proportional to the radius and the length.
This guy's gonna need some blood, so let's call the blood bank and get a massive transfusion.
With trauma, blood loss is best replaced with blood. Sure, we can use crystalloid as a bridge, but blood is best replaced with blood. If you need it immediately and don't have time for a group specific or group cross match, then using O negative blood in women of childbearing age, but O positive blood in postmenopausal and males is just as good.
Protocol going. All right.
Now a massive transfusion protocol may or may not exist, just purely because of logistics and the availability in rural areas. But what that actually means is pulling or asking for a pack, and the pack implies that the massive blood loss and hence replacement will inevitably lead to a coagulopathy. So mobilizing blood resources in terms of packed red blood cells as well as coagulation factors are really important and logistically very challenging and try to be bypassed with a massive transfusion protocol. The other thing that we often give is tranexamic acid, and that can be given in 2 bolus doses, 1 gram immediately and then 1 gram over 8 hourly. And the other principle with circulatory management is permissive hypotension, just raising their blood pressure enough, say 90 to 100 systolic, for perfusion of vital organs, rather than overdoing it and potentially disrupting any clots, except in the cases of head injury.
Control the bleeding there, control the bleeding there. We feel his pulse is down here. I think his traction splint seems to be working. He's got good pulses here with some bleeding there. It looks like an open femur fracture. I don't see any obvious bleeding on his chest. His abdomen is soft. His pelvis.
Okay, I think I might stop there.
So, Tracy, what do we got?
So the people factors I wanted to talk about again is those crisis resource management important principles I've already discussed. But what I wanted to move on to here was how this demonstrated nicely a concept called the 0-point survey. The 0-point survey is a really nice description described by Cliff Reed et al. In 2018 for the preparatory phase, that's the STE or pre-resuscitative phase, prior to commencing patient management by the doctor's ABCDE. So the P part, as we can see from the middle part, is the primary survey where we launch into it. But you could see from this video demonstration how it's important to have got this, which is basically how we talk about position, setting ourselves up for success. So self-check, and that's really important. That's another talk in itself in terms of mental readiness and physical readiness. These are a well-oiled team who've obviously trained together, but also they might have just quickly gone to the toilet, had something to eat, made sure they had a good sleep before the shift, but then using their own personal techniques to settle themselves down, to lower their heart rate, become a bit more clear-headed and ready for this resuscitation. The team, as you could see, had a clear leader, had role clarity, and a very extensive pre-brief with internal summary. Getting the environment right is really important in terms of light, equipment, reduction of noise. It was a very measured, tempered sound volume throughout all, and then launching into the patient. But during the resuscitative phase, we need to update where we're at. So once they got through A and intubated the patient, then he moved on to circulation, where he said that that was the most immediate, urgent priority that needed it, and started to change the team trajectory and the mission trajectory. So we have a clear lead, team and role allocation cemented by good communication, decision making, and the flow is assisted by anticipation and planning and prior preparation. So step up. And also, this is a nice document, a nice pictorial representation of knowing the plan, sharing the plan, and reviewing the risks. So in other words, having a shared mental model. Everyone has a good baseline knowledge. And note, please, that the leader doesn't have to be an expert in their field. They don't have to be a FACEM. They just need to have basic knowledge, basic skills, most importantly, a really good attitude and peak performance. And all this is linked in with maintaining situational awareness, not ending up going down into tunnel vision, clear decision making, good communication and teamwork, and good leadership. So procedures, I just wanted to show you some really handy links. Procedures, there's an app called Emergency Procedures, funny enough, that you can click on. Airway, breathing, circulation, and here's one on an LMA and outlining how to insert an LMA. Obviously, face-to-face is important, but this could be a good pre-reading tool. And I'll just click on that with this. Here we go. And that's the site emergencyprocedures.org, and then you can download the app, as we can see from there. Okay, so going back to the slideshow. With here, again, C, doctors A, B, C, D, E. And before we leave circulation, always think about where the areas of big blood loss are, the legs, into the abdomen and the chest and the long bones. With him, you noticed how he, the guy already had a splint on, but he was still hypotensive and there was a possibility of a pelvic fracture. And so putting on a pelvic binder would be part of the resuscitation and control of hemorrhage. Then, of course, to finish off is disability. Don't ever forget the glucose and drugs and exposure. And exposure is really important because exposure links into temperature, and temperature links into hypothermia. And there's the classic triad of badness or death that I call it, where enzymes and intracellular disruptions occur with hypothermia, acidosis, and hypovolemia, which is all the challenges that this patient faces. The other protocols that we can look at is a really good, useful site on the VicGov trauma site. And I'll just show you this. And here we have the Victorian state trauma system. And we can see how you can click on something like thoracic trauma. And you get a quick rundown, and then you can click on rapid reference guidelines, and you can see how this will just take you through everything that we looked at just now and the key points. And finally is the clinical practice guidelines from ambulance.vig.gov.au. This is a really easy to use site. Hang on a sec, I'm just trying to get onto there. It seems to be blocked off on me. So clinical practice guidelines, tap anywhere to begin, and then you can see adult, pediatric, maternity, newborn, and yeah, you can flick through that. All right. And finally, safety and quality. They recommend an ISPAR presentation, and that may be one of our most useful contributions to any critical care scenario is that clear communication. So in summary, tonight via 2 rural emergency cases, we have explored the protocols that help guide us in their management, from the ALS guidelines to Victoria trauma guidelines, and communication of their transfer by an ISOBAR framework. The procedural elements required to manage these cases, ranging from the deteriorated patient and immediate CPR to the deteriorating multi-trauma patient and potential for A, B, or C intervention. And finally, the people or human factor elements that underpin and cement all of this, ranging from calling for help, coordination, communication, and team management, and good decision-making, anticipation, and planning. And I hope I've highlighted this in these two videos. Okay, so let's have a look at the Q's and A's. So how to adjust defib dose for children, babies? Well, usually, first of all, Romani, the defibrillation is uncommon but can occur. Often children and babies have a hypoxic arrest, so there is more emphasis on airway and oxygenation. However, we would use smaller pads that would fit on their chest wall and use a joule per kilogram, as in 4 joules per kilogram. Does the patient need to be given muscle relaxant and midazolam when patient is intubated? Excellent question, Clement. We do. We give 2 different drugs. One is what we call hypnotic to make them unconscious, and one is to paralyze them, because if we need to insert an endotracheal tube, the muscles around the larynx are too tight. So if you've practiced on intubating on a mannequin, that is essentially a patient that's not paralyzed, plus or minus the gag. So we want to optimize our first attempt, and that's by giving muscle relaxants and having everything floppy. The most important thing to think about, one of the important points here is that when we're giving a hypnotic, which could be midazolam, but often ketamine is used, that we give a reduced dose. Some people talk about up to 1/10 of the normal dose, because remember, we've got a sick patient who is potentially hypovolemic and has got a a reduced total body compartment. So they don't need that much. Plus, also, these drugs rob them of their sympathetic drive, but also reduces their systemic vascular resistance. So it can drop their blood pressure. So you need to go low on hypnotics and high on muscle relaxants. Yep. Thank you, Tom. Fun fact, TXA dose. And yep, that's really good. Okay. Any other questions?
I think that's all.
Right.
Thank you so much. I just wanted to say, really appreciate your time tonight. That was a really interesting and really informative webinar. And to everyone that's attended, I just want to remind you to please complete the evaluation that will pop up in a moment when the webinar session closes. It really takes no more than a minute to complete. For those that attended, certificates of attendance will become available on your CPD statements within the next few days. But for any non-RACGP members who would like a certificate of attendance, please just email our rural team at rural@racgp.org.au. Lastly, I'd like to invite you all to join us for part 2 of our Eye Health webinar series. And I'm just going to post this in the chat for you. There we go. Michael and Alex will be with us on Thursday, the 3rd of April, to explore current best practices in diagnosing and managing common chronic causes of vision loss, such as glaucoma, diabetic retinopathy, cataract, and age-related macular degeneration. If you haven't registered yet for this free webinar, please do so by clicking the registration link in the chat. And that concludes our time this evening. Thank you everyone for attending, and I hope you all have a really good rest of your evening. Thanks everyone.